Hi, good afternoon. It's a Friday afternoon late request to lecture on ankylosing spondylitis. I'm off to a educational meeting for the weekend, but I'm happy to throw this out there. So, to try to summarize ankylosing spondylitis in 5 minutes is a little bit difficult. I'll do my best. Ankylosing spondylitis, ankylosis means bones fusing together, and spondylitis, or spondylo, refers to the spine, and itis means inflamed. So you have a condition where you have an inflamed spine fusing together. By definition, the spine has to be involved in the condition, and there are various factors as to who gets this, why they get it, when they get it. There are various associations. So, this is a common disease that occurs with features of inflammatory back pain. Okay, what is inflammatory back pain? Inflammatory back pain is the pain that you'll get throughout your spine when you wake up in the morning for absolutely no reason whatsoever other than that you were sleeping. To contrast this, people with a herniated disc tend to get worse when they lean forward. People with osteoarthritis tend to get worse when they lean back. People with nerve root compressions on the right or left tend to get worse when they bend to the right or left, depending on which side. But ankylosing spondylitis with inflammatory back pain can involve the neck, the mid-back. The mid-back would be defined as between your shoulder blades down towards, in women, the bra, or in men, above the hip bone or pelvic area, which is often where you have a kidney punch in that area. Below that starts the lumbar spine. All three areas are involved, often starting in the thoracolumbar junction, almost always involving the sacroiliac joints, and almost always bilateral, and almost always having a genetic marker called HLA-B27. Now, please note that HLA-B27 is positive in 10% of the Caucasian population in the United States. Please note that HLA-B27 clearly is different in various ethnic groups. Two examples. HLA-B27 is almost unheard of in sub-Saharan Africa, while HLA-B27 is present in almost 100% of certain Eskimo tribes in the very high northern latitudes. So you're at higher risk of getting this in northern latitudes. Men do get this more than women, probably by about 10 to 1. When women get it, they do tend to get it quite bad. If you have somebody who has HLA-B27 negative ankylosing spondylitis, there's a very good chance they do have a seronegative spondyloarthropathy, and if they have bilateral sacroiliac disease with symmetric spondylitic arthritis, the most likely diagnosis would be Crohn's disease, although this can be seen in sarcoidosis, Whipple's disease, and less often in that pattern in reactive arthritis or psoriatic arthritis. And anytime I would mention Crohn's, I would also mention ulcerative colitis, because they are indistinguishable in the axial x-rays. Okay, next. It can involve peripheral joints. Peripheral joints include the hands, wrists, elbows, shoulders, hips, knees, feet, and ankles. The most common joints involved outside of the spine in ankylosing spondylitis would be the hips, followed by the shoulders. However, you can have involvement of the DIPs. These joints, which are closest to the nails, are a DIP, or distal interphalangeal joint. These joints, which are your MCPs, or metacarpal phalangeal joints, much less likely. So you're dealing with predominantly large joints, which would be wrist, elbow, shoulder, hip, knee, ankle, asymmetric between 2 and 5 joints. You can have DIP involvement. You can also have what is called sausage digit. You can have associated uveitis, which is inflammation of the eye. If you have to distinguish the two, it is anterior, not posterior. It is very unusual to have posterior unless you have sarcoidosis. You can have kidney involvement with amyloid protein buildup after years of this chronic inflammatory debilitating disease. I hope this answers a lot of the practical stuff that the patient would want to know. So I'll just quickly move on to treatment. The treatment for ankylosing spondylitis in today's world is tumor necrosis factor inhibitors, and I like to typically use methotrexate with the tumor necrosis factor inhibitors, as I feel the combination works better than either drug alone. That being said, prior to biologic drugs, if somebody presented to an office or a clinic with between 2 and 5 joints large, they would be treated with sulfasalazine. The key here is that sulfasalazine, methotrexate, prednisone, methylprednisolone, and any other drug you can mention other than the new biologic drugs, and I refer to one of them as the tumor necrosis factor or TNF-alpha inhibitor. Other than the TNF inhibitors, no other drug can alleviate the pain in the lumbar spine, the thoracic spine, the cervical spine, or the sacroiliac joints. Occasionally we do sacroiliac injections. I believe this is the only appropriate time to do a sacroiliac injection. I do not think an elderly person who has low back pain chronically will ever benefit from sacroiliac injections, and I stand firm on those opinions. I'm sorry this could not be a more encyclopedic view into ankylosing spondylitis or the treatment, but I can do a follow-up lecture or answer questions as necessary. Thank you. Enjoy your weekend.